a 34-year-old female presents with progressive shortness of breath on exertion and recurrent episodes of lightheadedness. I am showing you her posteroanterior chest radiograph and an axial chest computed tomography scan. Describe the findings.
The chest radiograph demonstrates marked enlargement of the main pulmonary artery trunk, producing a prominent bulge along the left upper heart border. The central hilar pulmonary arteries are bilaterally dilated, but they taper rapidly as they course peripherally, resulting in hyperlucent, oligemic outer lung fields. The heart shows a normal cardiothoracic ratio, but with a rounded apex suggesting right ventricular configuration. The axial computed tomography scan confirms a dilated main pulmonary artery measuring 35 millimeters in diameter, which is significantly larger than the adjacent ascending aorta. There is also hypertrophy of the right ventricular free wall and flattening of the interventricular septum. These findings indicate severe pulmonary artery hypertension. In the absence of an identifiable secondary cause on computed tomography, primary or idiopathic pulmonary artery hypertension is the most likely diagnosis.
What is the clinical definition of pulmonary hypertension, and does a normal chest radiograph exclude this diagnosis?
Pulmonary hypertension is clinically defined by a mean pulmonary artery pressure greater than 20 millimeters of mercury at rest, measured directly via right heart catheterization. A normal chest radiograph does not exclude the diagnosis of pulmonary hypertension. In fact, up to 10 to 15% of patients, especially those in early stages, can have normal radiographs despite significantly elevated pulmonary pressures.
What is the main genetic mutation associated with familial pulmonary hypertension? What is the gold standard diagnostic test? And what are the primary treatment pathways for Group 1 pulmonary arterial hypertension?
Familial or hereditary pulmonary arterial hypertension is most commonly associated with mutations in the bone morphogenetic protein receptor type 2, or BMPR2 gene. The gold standard diagnostic test is right heart catheterization, which is required to confirm the diagnosis, measure pressures, and perform vasoactivity testing. Treatment pathways for Group 1 pulmonary arterial hypertension target three main pathways: the prostacyclin pathway using epoprostenol, the endothelin receptor antagonist pathway using bosentan or macitentan, and the nitric oxide pathway using sildenafil or riociguat. I would recommend referring the patient urgently to a specialized pulmonary hypertension center and cardiology.